First off, I want to thank everyone for coming here today. I know it's a wonderful meeting. We're all pressured on time to make it to all the different events. I am so pleased to see such an audience here for this today. It's right on time at 12:30, so I'm going to go ahead and get this started. We've got a wonderful presentation, a number of speakers. Again, my name is Dr. Rod Ellis. I'm the Vice Chair for Radiation Oncology at University Hospitals of Cleveland. They've asked me to moderate this session. I'd like to welcome my two panelists, Neil Mercedes and Walter Bosch, who are going to help come up with some questions for our presenters at the end of the meeting. But we've got three wonderful presentations. We're going to give each one of these gentlemen about 10 to 12 minutes to explain what they've done with the SpaceOAR product and how they've been involved in the research that's been involved, and then open it up to questioning at the end of the session. So with that, I'm going to introduce our first speaker, Dr. Marcio Fagundes, Medical Director, Provisional Center for Proton Therapy in Knoxville, Tennessee, who's going to give us a wonderful presentation on proton therapy and applications of SpaceOAR.
So I'm Marcio Fagundes, Medical Director of the Provisional Center for Proton Therapy. We're located in Knoxville, Tennessee. This is a beautiful picture of our center. And what I decided to subtitle my talk is my first 110 SpaceOAR cases. We have been following the progress of this product as it became imminent to be approved, and we're very interested to be one of the first to use it. And before we actually implemented the use of this product, John Sylvester here to my right and his colleagues, in fact, were kind enough to share some of the images that were used as part of the pivotal trial that he's going to be talking about in a little bit. And we used those scans contouring the plans or contouring the prostate and doing plans ourselves with and without SpaceOAR, but using proton therapy. And basically, we used 10 patient scans, generated plans, looked at doses, and looked at how much benefit we could achieve in terms of rectal sparing with the SpaceOAR comparing to without. And as you can see, we got our V70 rectal doses down to less than 1%. And that's quite evident in this DVH, where the V70 is essentially zero. So this was submitted in part of the PTCOG meeting last May. That convinced us that we really wanted to do this. So we had the privilege to be actually the first user in external beam therapy to do a SpaceOAR placement in the first week of April, right after it was FDA released. What we wanted to do was to have, and I'll show some images, have immediate feedback as we did the cases. We imaged the patients to see what kind of results we were getting. We prepped the patients with fleet enema, pre-medication with Valium and hydrocodone, EMLA cream to the skin, and basically apical transperineal anesthetic. Now, keep in mind that we, as a freestanding, not a hospital-based facility, we wanted to be able to do these procedures as an outpatient and do it as seamless as it could be, similar to a fiducial case. And that's what we have been doing now for the longest time. So we wanted to make sure that this would not add too much time or complexity to what we were doing. And the first 4 cases that we did all on the same day were done with very much ease. These are the pictures of the 4 cases. All these 4 patients were planned to undergo treatment to 39 fractions with proton therapy. And you can see their V70 rectal doses. And by the way, that is using a posterior expansion of 5 millimeters. So the V70s were 0, 0.3, and 0.8. So we felt pretty comfortable as we started with these first cases. Now, I want to show what we do to keep this as a simple outpatient procedure. Obviously, the pre-medication I showed you. The 3 important aspects is that you want to numb the right part of the apex right against the capsule with lidocaine. I numb up the track of the needle right up to the apex, but not going really under the prostate. I don't want to distort the plane of the prostatic fascia that could affect my ability to see it as I come in with the needle for the gel itself. And then the left apex. And you see the hypoechoic signal there is the numbing medicine. So this is a video that shows the needle being inserted. And we're going right under the retroprosthetic fascia right there. It's staying in front of the rectal wall. And now we see the hydrodissection taking place. So the needle goes to the mid-prostatic level, and that's our hydrodissection. I want to show this other video because it's interesting that sometimes you don't get enough separation that seems to go all the way to the base. And I've noticed after doing so many of these that sometimes the gel won't cover your base to apex length. So what I do is, I show you this video, I may start the hydrodissection at the mid-prostatic space, and if I don't get enough separation here, I just advance the needle another centimeter or so and give a little bit more push of saline, and that's your separation, base to apex. Now, I always advocate that you need to go back to your axial view. You need to make sure that your needle is perfectly midline, and you need to make sure that the saline is actually separated or dissipating bilaterally to both sides. And the needle is close up against the prostate. Here's the probe and the rectal wall. Because if the saline is going offside, just one side, that's typically where the gel is going to end up. So you want to make sure it's going both ways, left and right. This is the video that shows the gel going in at this point. And this takes about 8 seconds to happen. So there you have that. And that's the gel, it's all in. So now we wanted to have immediate feedback as we started this process. So what we did is we actually did, and you can't see this image from the back, I would think, because of the brightness, but we actually did a CAT scan of the patient prior to the gel, immediately after, and then we went on and did the MRI same day. This is like within 2 hours. And that gave us the confidence that we could see the gel fairly well on CT, but we could see the gel perfectly well on MRI. And then we brought the patient back 5 days later for the planning MRI and CT. Well, now we have the sagittal image here. You can see the full length of the gel. You can see the gel on CT here as well. And here's the MRI. Now, notice that if you do the MRI immediately after the gel, some of the brightness is saline. That's going to reabsorb over time. So you see how different these images look. Now, the interesting case is that our very first patient is a urologist. And so this urologist had already been planned to undergo treatment with balloon. And then I called him up and said, well, the gel was finally approved. Do you want to come back and do gel? And he said, yes. Well, turns out that we already had a scan done with him with balloon in for planning purposes. So he came back. And then we have the opportunity now to compare the balloon plan that we had done with him with a no balloon and finally the gel. So the empty rectum is what we did before the gel was put in, remember. Empty rectum, we did the scan first before putting the gel in. So this is what our V70 isodose would look like, 10%. And then with the SpaceOAR, it was 0. So again, this is our very first patient. It gave us a good opportunity to compare the various modalities that we were using. Now, it's always good to have a difficult case because, you know, if you have a difficult case, you kind of run into an obstacle. You say, well, this is not necessarily that straightforward. And, well, this challenging case was actually a patient with history of TURP, anal fissure operated on, and with history of hemorrhoids in the past, not active, no active bleeding. And we wanted to avoid using a balloon on this patient. We wanted to avoid radiating his rectum. So we went about doing the gel, and you can see that we didn't see much base hydrodissection when we did it, and the gel definitely didn't reach the base fully. The gel also didn't separate laterally as much as we wanted to. But guess what? Ultimately, we were able to get his V70 rectal dose down to 0.3. So this gentleman went through treatment very, very well. He didn't have any symptoms during treatment. This is his DVH. As I said, the V70 is essentially 0. So despite the not ideal hydrodissection and gel disbursement, we still have adequate or ideal dosimetry. Now, we use MRI for image fusion and planning. And if you use MRI, what I would, suggest, because I went through this process, is use fiducial-based MRI. And you can have fiducials that you can see on MRI, T1, and you see it right there. So we do the fusion by using the fiducials, and ultimately improves accuracy in delineating the gel and ultimately delineating the target. Now, just one or two slides on proton-specific images. We use intensity-modulated proton therapy, obviously, that requires pencil beam scanning to do. That improves our conformality of the posterior portion of the prostate, where the gel may impinge on the prostate somewhat and cause a concavity, similar to what a balloon would do. So here you have a lateral beam coming and stopping right here. We use lateral pose fields. We can trim down the dose where the gel is as much as we want by pulling out spots or decreasing the spot weight, as in reducing dose. Here's the opposite lateral field ending right there, and that's the composite dose. So we can keep the rectal dose to the 90% or less by using this kind of methodology. So what is our tolerance and experience with these cases? After doing 110 of these as a week or so ago, I can tell you that the only patient that had some trouble during the procedure was the patient that I showed you, the challenging case. And that was because of the scarring effect that he had. He had some pain during the procedure, and despite pre-medication, but the only one. And his symptoms of discomfort lasted about 2 weeks, and that was pretty much it. Throughout treatment, he did perfectly fine. I had one other patient that the gel looks fine. I record every case with a video capture card. I looked at his case afterwards. Everything looks very good. But he had bowel frequency and urgency, just having to go to the bathroom very frequently after the gel was put in. This lasted about a week, and then it's gone. But that's it. No patients had any complications. You know, just to say a word or two about motion, no, we don't use balloon, we use gel. In these cases, not both together. We are looking at pre and post treatment filming, and we're looking at how much the prostate moves. Now, we deliver the treatment in about a minute each field, and we pre and post film, and we're observing now that the motion, based on fiducial accurate assessment, the motion is less than 2 millimeters in more than 95% of the sessions or deliveries. And this is about what we observe with balloon. So we don't have concerns about increased motion using gel and not having a balloon. Now, keep in mind, we have patients on a low residue diet and stool softeners throughout the course of treatment. So what I would say is that as this is our first, experience truly with protons and SpaceOAR, that this is a practical outpatient procedure. It has excellent patient convenience with the numbing and prep technique. There are no complications noted, excellent patient tolerance during treatment, and a very high satisfaction rate with patients avoiding the balloon. What I'm used to now, seeing patients on a weekly basis for checkup, is that patients will tell me that they're absolutely fine. There are no symptoms whatsoever. They don't complain about some of the balloon issues that could require some, creams or suppositories from time to time, and they're just very, very happy. Now, I want to welcome any one of you who want to sign up to come to our center and visit. We are, a training facility for SpaceOAR placement, and this can be arranged with the company, and you would definitely be welcome to do that. And I want to thank our staff. This would not be possible without the help of a lot of people. Thank you so much.
Dr. Fagundes, thank you very much. That was an excellent presentation on the applications of the SpaceOAR technology. I'll let you pass off the mic. I'd like to go ahead and start the introduction here. John Sylvester certainly is known very well in the GU community, has worked with us for many years on many projects, but worked with me on the SpaceOAR trial. He's going to talk about the results of the trial that got the FDA approval for the product, and so I'll turn the mic over to him at this point. We are going to have questions at the end. I want to remind anyone this is being an audio recording, and so if you have a question at the end, feel free to come up to the mic. We just want to make sure people can hear your voice.
All right, I'd like to thank you all for inviting me to speak about the results of the U.S. pivotal trial. Now, what this was a randomized evaluation of the SpaceOAR system, and it was used to create space between the rectum and prostate in men with low risk and favorable intermediate risk disease. and it was a randomized, multi-center, parallel-controlled arm study. Now, the reason this was done, of course, was we want to see what we can do to reduce rectal toxicity, and with 3D conformal radiation, grade 2 plus rectal toxicities, maybe 20 to 22% or so. Move on to IMRT to present, maybe 10 to 15% grade 2 plus rectal toxicity, but there's always room for improvement. So what this SpaceOAR system is these precursor liquids that polymerize and form this polyethylene glycol gel. And so as you saw from Marcio's presentation, you put the needle between D'Anvier's fascia and the rectum, hydrodissect with about 10 cc's of sterile saline. You leave the needle in there, you take off this apparatus, you take off the saline syringe, and you hook on the SpaceOAR apparatus, and you inject the plunger simultaneously, and these things polymerize, and you have your gel creation within 10 seconds. So you can't push it too slow. You want a nice, smooth 8 to 10 seconds plunge. And that shows up very well on the MRI scan. And it lasts for a good 4 months or so before it degrades and hydrolysis absorbs and is completely gone within about 6 to 12 months. So this study was randomized. There was 20 U.S. sites. The patients were all treated with IG, IMRT, with or without SpaceOAR. It was a 2-to-1 randomization, so 149 patients received SpaceOAR and 73 were controls. Low to favorable intermediate risk patients, so like Gleason 7 with 50% or less of the cores positive, or PSA between 10 and 20, or low risk. Standard radiation protocol IMRT, 1.8 gray per fraction, 79.2 gray. All the patients had CT, MRI planning. All the planning was double-checked at independent core labs so that to make sure that dose constraints were met both on the SpaceOAR patients and the controls. So these criteria were really looked at, and you couldn't treat your patient until it was approved. So even the control patients had extremely good dosimetry compared to your average IMRT patient. So they'd be expected to have maybe less side effects than you might see in the typical population. The follow-up was every 3 months post-index procedure. The index procedure was when we put in the fiducial markers plus or minus a SpaceOAR. And so it was every 3 months, and they did EPIC questionnaires. So the primary effectiveness endpoint was having greater than a 25% reduction in the V70 in at least 70% of the SpaceOAR treated patients. Anesthesia could be general, local, conscious sedation. They all got antibiotics, 95% got antibiotics. Remember, this is a transperineal approach for both the fiducial markers and the SpaceOAR. All adverse events were evaluated by a blinded independent clinical events committee. As I mentioned, all the treatment plans, both pre and post index procedure, were evaluated by independent core lab. And 99% patient retention through 15 months. I had one of my patients had to drop off after about 6 to 9 months because he got diagnosed with locally advanced pancreatic cancer. I think there were actually 2 patients who got pancreatic cancer that dropped out, but otherwise retention was excellent. So what happened is you did informed consent in the clinic. Patients got a CT MRI plan number 1 done. You ran your plan, got it approved, and then you brought them back, did the fiducial marker placement, lithotomy position, and then after the fiducial markers were placed, while the patient was still in the lithotomy position, we opened up the envelope and found out if they were randomized to SpaceOAR or not. Did the SpaceOAR injection if they were randomized to SpaceOAR. About a week or so later, another CT MRI to do the actual treatment plan. Once that was approved for both the SpaceOAR patients and the non-SpaceOAR patients, moved on to the actual standard 1.8 gray, 79.2 total dose IMRT, and then post-index procedure at 3, 6, 12, 15 months, patients filled out the EPIC questionnaires. So that first 3-month questionnaire was only about a week or 2 after they finished treatment. These are the centers involved with the study. So we covered the whole breadth of the United States. This is the apparatus. You have the precursor fluid and powder. You mix that together, and you have this other precursor fluid. It all hooks together in this Y adapter. These plungers are hooked together with a plunger holder device, so that when you inject it, they go in simultaneously The fluids mix in the Y connector and polymerize within the body within about 8 to 10 seconds. So Marcio already showed you how it's done, but I do want to say, you want to make sure you got an angle going down so you avoid where the rectum comes up anteriorly. Anybody who's done much brachytherapy should probably find this to be pretty easy to do. And what we found was that post-implant, they had, of course, they were treatment planning CT MRI scan about a week later, and we had 12.5 millimeters of space separation in the spacer patients. After spacer, of course, not before spacer. And the controls, of course, there's no difference between fiducial marker, pre and post. You still see excellent space separation at 3 months, so plenty of time to get your radiation beam done. And by 12 months, it's all gone. You see the DBH data for the V70, V65, V50 across the board. The spacer patients post-treatment compared to pre-treatment, dramatic reduction in the rectal doses. And for all the spacer patients, all of them are downward trending. There is no significant difference, of course, in bladder DVHs. It's not meant to decrease the bladder DVHs. Even the controls, though, had excellent dosimetry, and I think that's because the independent core lab really hounded people to make sure the dosimetry was really spot on for even the control patients. So looking at toxicity data becomes more challenging when you got a control group that is treated so well that they're not expected to have a lot of toxicity. So again, the patients post-treatment filled out the EPIC questionnaires. In terms of safety results, really no significant issues. There was no device-related adverse events, no delays to onset of treatment, no infections, no rectal wall ulcerations. A few patients had mild transient perineal discomfort that disappeared quickly. It was why they were sitting. In terms of serious adverse events, no significant difference between the spacer group and the non-spacer group. Remember, it's a 2-to-1 randomization. When you look at toxicity results, no difference in acute rectal toxicity, but there was a difference in acute rectal pain in that the spacer patients, only 2.7% had pain during treatment, while 11% of the non-spacer patients did. And in terms of more longer follow-up, there was a 2% risk in the spacer patients of grade 1 or higher rectal toxicity versus a 7% risk in the non-spacer groups. And that 7% is certainly less than what you typically see in most settings, but I think that's because of the QA that was done on these patients. No difference in urinary side effects. Here's an example of one of our first, I think it's my first patient actually. You got the prostate, the 100% isodose curve. You can see on the MRI scan, prostate outlined. We do the spacer, and the spacer's right here. You don't really see it well on CT. Maybe a little bit of lack of contrast there, but on the T2 you can see it quite well. So basically the 100% isodose curve does not hit the rectum at all. And sagittal image, again, you can see excellent coverage. So what we had is in the study, reliable space creation, the average was 12.5 millimeters. Significant dose reductions across all the meaningful rectal DVHs. And decrease in rectal side effects, where 1 out of 14 of the control patients had rectal side effects versus 1 out of 49 in the spacer patients. Procedure time, needle in to needle out, is about 4 minutes overall for all 20 centers. Some centers may be 1 minute faster than others. Significant reduction, not 25%, but 73% received greater than the 25% reduction. 97% greater than 25% reduction, but most got 73% reduction in the V70. No unanticipated adverse device problems. Significant reduction in pain and some improvement in quality of life as well. So that's the IGRT stuff. Now, of course, I like brachytherapy, so we got to talk about brachytherapy here a little bit. And there's been a couple studies using spacer-type materials for brachytherapy. First was in Spain, randomized trial, 69 low to intermediate risk patients, randomized to hyaluronic acid or not, and they all got I-125 monotherapy, 6 to 8 cc's of this gel-type stuff injected. They looked endoscopy on the patients at 18 months, and they looked at rectal side effects. And the mucosal damage seen on endoscopy on the patients that received this spacing was 5% in the patients with the spacing versus 36% of patients that could see changes on endoscopy if they didn't get the spacing. And there was no rectal bleeding in the patients that got spacing versus 12% had some rectal bleeding if they didn't get the spacing. That's a randomized trial. Now, there's also a trial out of Australia where they looked at their patients they did seeds on, they looked at their post-op dosimetry, and the patients that had high RV100s. So, you know, you want to have an RV100 of less than 1. And so they saw 5 patients that had a mean RV100 post-brachytherapy of 3 cc's. So they went back and did the hydrogel injection, and they dropped their RV100 down to 0.06 cc's. So it's also something that can be done easily after brachytherapy. The patient's already positioned under anesthetic. You got the grid, you got the ultrasound. At the end of the case, you put the needle in, hydrodissect, and then inject the gel. And so I've done that on several patients since FDA approval. And that's worked out quite well. So it's, again, FDA cleared in April. What we have, we look at the history of rectal doses over time, 3D conformal versus IMRT versus IGRT versus with spacer now. We're less than 5% RV70s. Oh, thank you.
So I'd like to thank John for giving an excellent summary of the clinical data that got the FDA approval. Again, as you're aware, this is FDA approved to put a space between the prostate and the rectum for any form of radiotherapy. So that's when we started with the protons, had John speak a little bit to the clinical data, to the brachytherapy. But I want to bring a man to the mic who's synonymous with stereotactic radiosurgery. While I was the first person to get SpaceOAR and brachytherapy, and he was the first one to do it for proton, I'm sure you were probably the very first person to do it with SBRT, if I had to imagine, Bob. So I'm going to introduce Bob Timmerman, who's going to present to us the concept of using SpaceOAR with stereotactic radiosurgery for prostate cancer. Welcome. Thank you.
Thanks a lot. All right. So this is specifically to talk to you about applications to hypofractionation. At UT Southwestern, we envisioned treating prostate cancer with stereotactic radiation. Starting back in 2003, we got a DoD grant to try to move that forward. We're sort of cautious about moving forward. We thought that the most important toxicity would be urethral, because it's right in the middle of the target to an ablative treatment. But we also took a lot of precautions for the rectum, and you can see this rectal balloon in place for the patients that were treated, and we divided the rectal wall into 4 compartments to try to really understand what part of the rectum was associated with the toxicity. But again, the primary focus of the IMRT, at least, was to spare the urethra. So we identified the urethra with a pediatric catheter and then really tried to carve the dose around it. And it just goes to show how you need to do clinical trials, because although we had a bit of urgency early on in the experience, that was treated effectively with Flomax, and we really haven't had much urethral toxicity, but we did have some problems with the rectum. Not knowing what dose to use, we wanted to find the boundaries of the therapy, primarily focusing on high-risk patients in the end. The original trials were in mostly intermediate-risk patients, but high-risk patients are the ones that die of prostate cancer, and we ultimately wanted to have a more effective therapy for the people that actually die of prostate cancer. So we were going to go to much higher doses than you've probably seen in other experiences to find those boundaries and to know what the limits are of the therapy. So these are the doses we tested in that phase 1 study, 15 patients per arm, so that was about 45 patients. And 2 patients experienced a small amount of bright red blood on the initial dose cohort. And so my brother's a colorectal surgeon. He taught me quickly how to do anoscopy, and so we did anoscopy in all those patients. And what we found on anoscopy, to our surprise, and I hope you can see this well, but there's a fairly demarcated, dime-sized superficial ulcer that was present in every patient that we treated. And that was quite striking. So the incidence was 100%. but the patients didn't even know they had it, except for those couple patients with the bright red blood. And ultimately, the resolution of that was 100%. And we scoped them every follow-up period to see how it evolved, and it went away in all patients over a period of about 3 months. So the harsh reality that we had to understand was that at even the lowest dose level, this 45 gray in 5 fractions, every patient had a ulcer that fortunately resolved, and so it healed. So that was the good news. And the dose volume constraints that we were using for SBRT, and it's not V70, but there were other things that we had put in there, did not do the job of preventing this, at least imaging toxicity. Compliance was 100% with dosimetry, and again, the large percentage were asymptomatic. All patients were injured, nonetheless, they all healed, at least at the lower dose levels. We went on to do a phase 2 study, again, mostly in intermediate risk patients, and you treated at the most potent dose, 10 gray times 5, and we treated all patients, and then we put a moratorium on ourselves for 3 years. We didn't treat another patient, waiting to see what kind of toxicity evolved. And indeed, there was late toxicity. And what we found was that the treatment itself, in terms of efficacy parameters, was very good. 75% of patients had potency preservation that were potent prior to the treatment. And the biochemical control rate, which probably shouldn't be too surprising at these high doses, was 99% at 5 years. But we saw this unexpected toxicity pattern. Even though the phase 1 patients treated at the highest dose are still doing fine, in phase 2, there was an unacceptable rate of high-grade rectal toxicities. Effectively, what happened is that ulcer I showed you on the scan did not heal in a very small percentage of patients. And that led to surgical interventions, including diversions, which is, of course, very bad. And this is kind of what that looked like in one particular patient. At 12 months, we see this ulcer that doesn't want to heal. By 18 months, we do a diverting jejunostomy. And by 36 months, it's starting to heal, but it's still quite a defect in the rectal wall. The best treatment for radiation-induced ulcer or fistula in a patient is a myocutaneous graft that involves transferring muscle and skin to the area of the defect. The muscle effectively gives cushion and a blood supply, and the cutaneous part gives stem cells for regeneration of the mucosa. So there are 2 mechanisms of injury associated with a rectal ulcer from radiation. One is a dysfunction in stem cell migration. We're not getting enough stem cells migrating to the front to cover up that defect, because all these things heal by second intention. And the other problem is after a journey, maybe from the posterior rectal wall to the anterior rectal wall to cover that up, it doesn't find a hospitable environment. That is, there's not enough blood supply or tissue underneath so that those stem cells can reform an epithelium. And so what we looked at then in our hypothesis testing to see if we could come to terms with this is how far can stem cells migrate before they're unable to reach the anterior wall, because all the toxicity is going to occur on that anterior wall of the rectum. And how do cells migrating around, how far can they actually go before they can't reach the finish line? And what we found was that there were 2 doses that were important. At 24 gray, there's a depletion of stem cells, and at 39 gray, there's a total eradication of stem cells. And so we were measuring percent circumference migration. This is nothing that you can get off of a dose volume histogram. And the correlations were amazing. This is in regards to the 50 gray dose, which we found to be correlated to the vascular problems. At a certain cutoff, if that 50 gray dose had a certain volume of anterior rectal wall, all of the toxicity occurred, and below that line, none of the toxicity occurred. So what we found was striking correlations by looking at causative mechanisms rather than just a fishing expedition. So here's 2 patients, both of them complying very well with the protocol. And here, the 50 gray line, again, that's associated with vascular damage, treating a fair amount of rectal wall and the anterior wall. And in this patient, not very much. And in addition, here's the 24 and the 39 gray line, markedly different between these 2 plans. Where in this plan, they actually tried to avoid that rectal wall, and in this plan we didn't. Both met the constraints of the protocol, which were obviously woefully inadequate. This patient has a rectal ulcer, this patient doesn't have a rectal ulcer. So the damage repair model looks like this. Normal epithelium for the stem cells are in the crypts, and they can migrate forward. And if the 24 gray line is treating more than half of the rectal circumference, we see acute problems with mucositis. And if the 39 gray is treating more than a third of the rectal mucosa, we see high-grade toxicity, as well as if the 50 gray line is more than 3 cc's, we don't see the vasculature able to sustain them once they get there. So these are very striking correlations and sort of beg the question, what if we could separate the rectal wall such that that 50 gray line, instead of hitting the rectum itself, would be spilled somewhere else. So if this is the 50 gray line, in the ordinary case, it's kissing the anterior wall of the rectum, and obviously if you put the spacer in, it misses that line. And so we wanted to use the spacer sort of as soon as we realized this. They were still working on their FDA approval. A colleague of mine in Italy, Angiolo Tagliagambi, had gotten the spacer and had started doing work with the spacer using a similar dose fractionation regimen in prostate cancer, getting promising results. So we were quite excited about eventually getting this, and once it was FDA approved, we did form a collaboration, and we're doing a trial right now where it's basically a repeat of the trial that I just showed you, again, mostly in intermediate risk patients. They're getting 45 gray in 5 fractions because we had excellent PSA control at 5 years with that. And the primary endpoint is toxicity, but it's an interesting toxicity. We're going to do that anoscope again and see if it occurs or not. So we can actually have a fairly small sample size. Because we did a prospective trial last time, we have good solid data to justify our statistics, and this trial will be around 40 patients. And so what we're doing now is with the spacer in place, we're contouring and overlapping with MRI. We use the fiducials from MRI and CT to be merged, and then the spacer's in place, and we're carving the dose around the prostate. We treat the full prostate, no cheating on the posterior part of the prostate like it's done in a lot of IMRT trials. And these are the dose distributions that we're able to get. And now the doses aren't showing up, but the 50 gray line is clearly in the spacer, not in the rectum. And in fact, the 39 gray line is not in the rectum either, just a little bit of dose from the 24 gray line. You can see that better in the sagittal view. So all these toxic doses are now in the rectum, in the spacer, where they can do less harm and not in the rectum. So the impact of the spacer is that our rectal doses, this is accruing like crazy. We've already enrolled, just in a few months, 20-something patients, so it's incredibly popular. We're getting low rectal doses even without much IMRT. That allows us to use IMRT to spare other things. And so we're sparing the penile bulb better, we're sparing the bladder better than we did before, because we can afford to push more dose in the rectal direction. And ultimately, we'd like to paint dose and perhaps even spare one of the nerves on one side to the prostate for potency, just like the urologists do nerve-sparing prostatectomies. We'll be doing nerve-sparing radiation treatments with SBRT. And then we'll move on to our high-risk trial, our phase 1 trial in the high-risk population. We're actually going to use 9.5 gray per fraction of the prostate and the seminal vesicles. We're also going to treat the lymph nodes, escalating from 4.5 to 5.5, just the lower pelvic lymph nodes, and then eventually paint the lesions based on MRI visualization from 9.5 all the way up to hopefully 11 gray, which again I think we can do with the spacer in place. A little bit of soothsaying, given the fact that patients are seeking out more convenient treatments for prostate cancer, and the 30, 40 treatments are not convenient at all. Given that we're seeing very good biochemical control with these stereotactic treatments, and we could potentially even improve outcome in high-risk patients, and since with the spacer especially, we should probably be able to get very good toxicity profiles, I predict that SBRT will be the treatment, that the indicator treatment for prostate cancer within the next 5 to 10 years. And that might be with protons, but I think even with photons you can do a good job with these kinds of things. So in conclusion, DVH planning has sort of served us well, but it has its limitations, especially when it relates to mechanisms of injury. I think prostate SBRT has an extremely bright future with high tumor control, and the patients are clearly excited about the SpaceOAR based on our enrollment by adverately avoiding these rectal complications so that we can focus elsewhere on even making the treatments better. Thanks very much.
So that was an exciting engagement from all three speakers. I think it really raised a lot of thought, provoked some questions. I'd encourage anyone in the audience that has questions, if they'd like to start. Otherwise, I've got a number of questions I'll present to the speakers. But if you'd like to step up to the mic, you're welcome to ask them if there's anything you want to know about either the technology or the applications and different forms of radiotherapy. Yes, sir.
I have a question for Dr. Timmerman. With the high-risk patients, do you still use hormonal therapy with the stereotactic radiation?
Risk patients, even though you could use hormones theoretically, we only used hormones to downsize the prostate. We were trying to mimic brachytherapy effectively. So in an occasional patient that had a big prostate, we would give them one injection of Lupron, hoping the prostate would shrink. But in the high-risk protocol, we will use hormones as a standard of care.
Go ahead.
I noticed all your trials were with Gleason 7 or less. Are you reluctant in a relatively low risk Gleason 8, 9, 10 to use this?
I desperately want to use it in those patients because, I mean, they're getting prostatectomies, which to me seems crazy. And if we could offer an alternative treatment that would compete with prostatectomy for high-risk patients, that was convenient and especially if it improved the cure rate, which is going to be the goal, then I think we could take those patients back instead of treating them post-op.
Yeah, if you look at radical prostatectomy series, it's extremely rare to have invasion through Dion-Vies fascia. Sometimes you'll see it into Dion-Vies fascia, but actually go through it is very rare. So injecting this gel into the space posterior to Dion-Vies fascia is going to be unlikely to miss disease. And with high-risk disease, you could always look at treating a little larger volume initially to kill microscopic disease you might be worried about, and then reduce field boost a higher dose to the actual prostate itself.
Of the patients that we treated so far, some of them are high risk. We're treating lymph nodes with pencil beam scanning, and essentially we're just excluding those that have posterior capsule invasion. That plane is blurred on the MR. But if there isn't posterior invasion, not through the fascia, but through the capsule, then we treat them. But if there is proven invasion, then we're going with caution on those.
So we've talked a little bit about prostate brachytherapy, typical IMRT. We've talked about stereotactic radiosurgery. We didn't have anyone on the panel address high-dose rate brachytherapy. You know, many of us look at brachytherapy for HDR and even talk about a single monofraction. Would anyone on the panel like to comment to that? Because although I've used it after HDR or LDR brachytherapy, I believe if you do this with HDR, you'd have to place your spacer, and it may alter how you do the planning. I just thought I'd let the audience hear from the experts at the panel what their thoughts are on HDR as well. Anyone want to take that? I know, John, you have some comments.
Yeah, well, I think it can be done with HDR just as well as with LDR. You know, by the time the patient gets the needles inserted, he's got to go to the planning simulator. You got to run your plan. There's plenty of time for air bubbles or whatnot to resolve. And so you should be able to do your plan just like you would with an LDR case or an IMRT case. So I don't see there be any restrictions in HDR.
That's very helpful because, again, I've seen it done with LDR, and immediately after you inject, you lose your image. But I've not waited 15, 20 minutes to re-image, so that was helpful. Go ahead, sir.
If you have any experience using this in previously radiated pelvises, like in prior rectal cancer treatments?
Well, I've done it on several patients now since the FDA clearance that have had recurrent disease after either external beam or brachy, and so far no problems with hydrodissection, although you could run into a situation that Dr. Fagundes mentioned where you might have scar tissue. So I warn these guys that we might get in there and find we can't hydrodissect. But so far, no problems.
No, that's
Yes,
interesting.
Paul Newman also did a case report on using. Paul Newman from the Harvard system did a case report on a patient that he did hydrodissection on a patient who was post-brachytherapy. And that was a surprising thing, but he was able to get that through. So it's been done.
That was interesting that we talked about whether it could be done in the operating room under a general anesthetic or in an outpatient setting, as Marcio's been doing with the protons. Obviously, you talked about your patient that was a difficult patient because it was difficult to hydrodissect. If they're under an anesthetic, they may not feel that, so it might be an indication to do it in the OR. The question is, who's it appropriate to be done by? And that's one of the questions I wanted to bring up, is that I think the urologists, feel that they can do this for us, obviously. I think most radiation oncologists, especially if they're brachytherapists, are going to be very comfortable doing it. For those that have not done it before, then the question is, how quickly can you adopt and learn this technology? I'll let each one of the speakers kind of speak to those 3 points. Who should do it? How hard is it to do it? Where should it be done?
Yeah, I mean, I found it really easy to start this, having had all the brachytherapy background, and I think that I have this knowledge or impression that we understand better what we need in terms of what to separate from what to get the best dose. I'm not sure that all urologists would have that vision as they're doing the procedure, how to displace what, and if you have some compromises to make, what is the best compromise to make for dose optimization later? So, I mean, ultimately, I think we probably do a better job at it, but I guess anybody could learn, as long as they know ultrasound, transperineal approach, do the proper numbing, and keep this as an outpatient procedure, because if we make it complicated into the OR, it's just too much time, cost, and all that. We have to be able to do this as an outpatient, and it can be done. I mean, that's what we do every day.
So that would be one of the next questions. As we start seeing this go to the mainstream and people are doing it, I suspect many of the people that are in this audience may end up being on the RUC committee that try to figure out how difficult is it to do this procedure and setting it. How many patients do you think you had to get through before you felt comfortable? What's the learning curve like?
Again, if you've done much brachytherapy and used a transperineal approach, the learning curve was virtually zero. I mean, it was really easy to do. But when you deal with some urologists that haven't done much brachytherapy, they're used to transperineal biopsies, you could run into some issues. I think they did have some issues in Europe with the urologists trying to do it initially. So transperineal approach, they need to learn how to approach things that way, hydrodissect, and get the image plane. I think ideally, if a urologist is used to a transperineal approach and more becoming used to that with mapping biopsies, then they should be able to learn how to do it as well. So it's going to depend on your own local environment, and you may find it's a mixture where some urologists in your region will want you to do it, and others may want to do it themselves.
So either transperineal brachytherapy or transperineal fiducial marker placement, that'd be an equivalent procedure as far as difficulty?
Or mapping biopsies or transperineal brachytherapy is a good, if you can do that well, you should be able to learn how to do this really quickly.
Great. Bob, did you have some thoughts?
I personally don't do it, so I'm relying on other colleagues to actually put it in. I know in Italy they used the interventional radiologist to do it because that was what worked best in their situation. I sort of purposely, to get buy-in, wanted the urologists to be involved in this part of it, and hopefully they can get some billing codes for that as well. We're piggybacking it right now on the fiducial placement. We have a county hospital, and at the county hospital, the urologists are the only ones that have privileges to do these types of procedures, so we have to have them do it. And then at the private hospital, we have a few, even a PA urologist is doing it, and then one of our faculty is a Memorial Sloan Kettering trained brachytherapy guy, so he's doing it as well. So I kind of am covering all the bases. And yet, I do think it's not a bad idea to get the urologist engaged in this, because otherwise they'll feel like they're being left out.
Working at my institution, we've had quite an acceptance rate from the urologists to do this, and now more and more of them are doing fusion biopsies and through perineal biopsy, through perineal mechanism, and so we have the urologists doing these as well, and they seem to like being part of that process. But as far as an acceptance rate and a learning, it's a very steep learning curve that we find that the physicians get very comfortable with it very quickly.
Walter, did you have any comments? Looks like we've got one more question from the audience.
Okay, so I know it's approved April 1st this year. Have you guys had any problems with getting reimbursed for this?
So I can tell you in our
practical
experience,
question.
We purchased the product within our Department of Radiation
Okay.
Oncology and used it almost as a compassionate use on the patients I thought were high risk of rectal toxicity. And so we've just now, I think, started to bill for the procedure. There is a C code for hospital-based. It's still working on CPT coding and reimbursement, so I think that's a work in progress. I think the company and the representatives that are here could speak to you more about that, but that's a work in progress to get it reimbursed at the appropriate level to account for the complexities of bringing this technology to market. Can you speak to the microphone, please?
Is it reasonable to use a fiducial placement code? Just a thought.
I think it would be reasonable to use an unlisted code and ask for reimbursement with documentation and look to see what your local market reimburses at. And again, I know the company's got some excellent representatives that will help with individuals that have questions. Any other questions from the audience? Pat or anyone? I think I hit most of the questions that I wanted to go through. Again, I'd like to thank everyone that took the time to come today. I know we've got a lot of meetings that we're all trying to make it to in this important ASTRO symposium. But it was a wonderful opportunity to have so many people come and hear about this today. So thank you all very much. If you have any questions, there'll be people around afterwards to answer them. Thank you.